Good evening, everyone. I'm Dr. Aishwarya Sharma, and welcome to the Med AI Web Hour Episode 4, organized by Doctors AI in collaboration with MedSynapse. So, Doctors AI is a collective of clinicians who are passionate about how artificial intelligence is shaping the future of medicine, making care smarter, faster, and more human centered. Med AI Web Hour is our initiative where we meet every second Thursday of every month and at 9 p.m. and we discuss the spotlight in the latest innovations and real world applications of AI in healthcare. Today, we are thrilled to have two brilliant minds with us Dr. Anil Virmani, who will speak in AI in cardiology about the powerful present and the bright future that it holds. And for the second presentation, we have Dr. Prantar Chakraborty, who will take us from microscopes to the models as he explores AI in hemato-oncology. And guiding the conversation is our moderator, Dr. Shlok Gupta, an enthusiastic voice, a junior resident in general medicine. Along with him, I will also be there to moderate a certain session. I welcome you all, especially our speakers and our moderator, for taking such valuable time out for all the enthusiastic doctors all around India or world who are interested in this intersection of uh, artificial intelligence and healthcare. Dr. Shlok Gupta, over to you. You may start with the discussion.
So a very good evening to each and everyone. Today on the 10th of April 2025, we have joined today again on for Web AI. It is a very interesting series of discussions, which gives a very interesting and a very intriguing insight uh, into the day-to-day needs and the emerging technology of artificial intelligence in clinical medicine and therapeutics. So today again we are going into the specialty. We're going into the fields of hematology, oncology, pathology, as well as we're going into cardiology today. We have with us Dr. Prantar sir and Dr. A.K. Virmani sir, who will be discussing and who will be giving their expert inputs in these in their specific in the special fields. So for the first talk, uh, sir is a consultant physician, cardiologist, diabetologist at Jamshedpur, cybercrime intervention officer. He's the dean of Indian College of Cardio, Diabetology and Metabolic Diseases. He's chairman of Indian Association of Clinical Medicine Jharkhand chapter. He's a faculty at New Yorkshire Foundation Teaching Program UK, and he's also on the executive council member East Zone RSSDI. Sir is an advisory council member and of Advanced Career Physician ACP. He's published number of chapters in API RSSDI update textbooks, JAPI and JIMA. He's recipient of Economic Times Healthcare Award for one of the most inspiring diabetologists of the country. Awarded the ACP Internist Award 2022, and he's the chapter leader. He's a recipient of a chapter leadership award of ACP 2023. He's awarded the Excellence Award as the best teacher award by Indian Society of Cardiology. So we welcome you, sir.
Today, My topic is the use of artificial intelligence in cardiology, a powerful presence and bright future. At the outset, I would like to express my heartfelt gratitude to my friends and mentors who have inspired me to learn about AI. Professor Dr. Shri V. Kulkarni, Dr. Alok Modi, and Dr. Amit Dey. Now, how fast AI is coming into our healthcare practice, you can realize by the very fact that in 2023, the healthcare workers were afraid that they will be replaced by AI. In 2024, they're not worried about being replaced, but they were worried about AI being designed and implemented without them. And in 2025, these healthcare providers are at the forefront of designing safe AI to create a better healthcare for all. So, what I'm going to do in the next 20 minutes is to talk about the uses of AI in clinical cardiology, what is the database evidence we have, what ethical dilemmas we face, and a peek into the future. Recently, in the American College of Cardiology conference held about 10 days back, there was a 1 hour panel discussion on the use of AI in cardiologists. And the goal given was save time, save money, save lives. And they said they put in 3 criteria which must be fulfilled before AI becomes rampant in cardiology. Number one, AI must reduce burden, it must support equity, and preserve the patient clinician relationship. To start with, in medicine, there is an ultimate need for the effective triage of patients, effective clinical evaluation, and incorporation of clinical expertise with the latest technologies and evidence based medicine, accurate decision making for the right diagnostic and treatment plan. Fortunately, cardiology is at the forefront of AI revolution in medicine. It allows accurate prediction of cardiovascular outcomes, non invasive diagnosis of coronary artery disease, detection of malignant arrhythmias, and diagnosis, treatment, prediction of outcomes for heart failure. The advancements in AI, the Internet of Things, and precision medicine are going to lead to further innovations in the field of cardiovascular research. However, we are limited by ethical and data privacy concerns which still need to be addressed. As we all know, heart disease or cardiovascular disease is one of the second biggest killers after COPD, with a prevalence rate of anywhere between 4,000 to more than 5,000 per 100,000 across India. To give you an overview of the role of AI in cardiovascular medicine, we have big data coming from the electronic health records, from the diet, ECG, genetics, wearables, lifestyle, software, and we have data coming from the various imaging modalities like CT, echoes, the cardiac magnetic resonance, and SPECT. And by machine learning and deep learning and computer vision, we have automatic diagnosis, continuous remote monitoring, improved decision making, treatment selection, precision medicine, and ultimately reduce costs. To go further into details, the big data that is coming now, we have data from both experimental, biological, clinical, and data coming from the wearables that are being used, which I'll talk about later. When we look at heart failure, we can know about how to prevent it, readmission reduction management. In preventive cardiology, we can risk stratify patients. There are multiple machine learning models such as naive Bayes, K nearest neighbors, decision tree, random forest, etc. And they have been used for risk prediction of adverse cardiac events following an ST elevation myocardial infarction. Then we have the advantages in diagnostic cardiovascular imaging, whether it be an echo, cardiac CT, or cardiac MRI, where we can identify and segment of various cardiac structures. We can do lesion identification and classification of images associated with different conditions. In electrophysiology, we can look at the heart rate variability, ECG monitoring, and arrhythmia detection. And also in interventional cardiology, we can look at the fraction flow rates and intravascular imaging. We have developed techniques now that by just looking at the face, images of the face, we can predict outcomes, major adverse cardiovascular outcomes, and coronary artery disease based on a single facial photograph is now available. In clinical cardiology, the basic aim is to improve the accuracy of automated ECG interpretation and aid patient stratification and prognostication. In fact, it can detect subclinical paroxysmal atrial fibrillation from ECGs with so-called normal rhythm, which have been missed by the cardiologist. By deep learning atrial fibrillation detectors, you can see on the lower right, patient had atrial fibrillation. Decision to start antithrombotic therapy for patients with newly diagnosed atrial fibrillation, because we want to know what is the risk of ischemic stroke, major bleeding, and death if we put these patients on anticoagulants. And gradient boosting machine, which is the best performing machine learning algorithm of all, has shown a significant improvement in predicting major bleeding in comparison to the conventional Has-Blood score and a death in comparison to the CHAD2-DST2 VAS score. So it can give us that information also. Now, this is a wonderful pragmatic randomized controlled trial done with AI-enabled ECGs for the potential of timely and early detection of ST elevation myocardial infarction in 12-lead ECGs. And it was shown that the AI-enabled ECG demonstrated a positive predictive value of almost 89.5% and a negative predictive value of 99.9%. But what is more important, in the emergency department, the median door to balloon time was reduced to 82 minutes compared to the control group, which had 96 minutes. So, what message we have learned from this trial? That the incorporation of AI-enabled ECG as an affordable clinical decision support system resulted in a significant reduction in door-to-balloon time, underscoring its potential to enhance the timeliness of care delivery. And it also demonstrated a promising accuracy in identifying potential STEMI cases, thus enhancing the attention of proactive management by healthcare providers. Coming to the investigation modalities like transthoracic echo, AI enables enhancement of imaging measurements accuracy. From a cardiomyopathy point of view, algorithms have been trained from clinical conventional echo data and speckle tracking echo to distinguish between constrictive pericarditis and restrictive cardiomyopathy. They have also been trained to exceed humans' experts' performance in tasks such as the estimation of ejection fraction, assessments of cardiomyopathies, left ventricular segmentation by using EcoNet dynamic. Cardiac computed tomography angiography has been using AI to maximize information extraction via image acquisition and improve diagnostic accuracy and prognostic outcomes via precision risk stratification. Now, let me show you some images. These are the how echo images AI enabled, how they can exactly automatic border detection can be done, and regional and global longitudinal strains can be looked at. Moreover, endocardial boundary refinements, segments like ventricle for the short axis view, you can detect both endocardium and epicardium, classify, optimize volume classification, and identify cardiac disease. The integration of AI echocardiography marks a pivotal shift in cardiovascular diagnosis, offering enhanced accuracy, consistency, and reliability. By addressing operator variability and improving diagnostic performance, it has the potential to elevate patient care and herald a new era in cardiology. The AI-based computed tomography coronary angiography can automatically assess this stenosis It can look at the hemodynamics, significance of equivocal or minor plaques. It can analyze the composition of the plaques, and it can also evaluate coronary uh, 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 coronary antihypertensive, anti-plaque inflammation burden. Ultimately, we can divide the patients into low, medium cardiovascular rate, high CV rates, or very high CV rate who require urgent revascularization. Coming to clinical cardiology, heart failure, asymptomatic left ventricular dysfunction, we can have early detection, classification, severity estimation, and prediction of adverse events. In cardiac resynchronization therapy for prediction of all-cause mortality or hospitalization at 12 months post CRT, heart murmur detection to enhance the precision of screening for both valvular and congenital heart diseases. And we know the Internet of Things, which is a machine talking to a machine, can be applied for remote health monitoring, chronic disease management, obedience to treatment, adherence to treatment, and medication at home and elderly care. In fact, we can identify cardiac emergencies remotely and by measured by an AI-enabled ECG can be transmitted via blue phone, via Bluetooth to a smartphone for data analysis, and further advice can be given. If there are a lot of wearables, we have the cardia band like the Apple Watch. There are multiple watches. There are almost every part of the body you can have a wearable. But what is very important in this is they're all non-invasive, safe, instantaneous access to patients, user friendly, and allow uninterrupted monitoring and instantaneous individual analysis of ECG signals. And recently, we have the digital stethoscope that can record wirelessly, but also use machine learning software to provide automatic arrhythmia detection, accuracy of 87%, and acoustic based automatic diagnosis of cardiac dysfunction. It can be uploaded online and can be used for teaching purposes. Now, to give you an overview of the US in AI in cardiology, as I talked about identification of various arrhythmias to this support vector machine, determination of the hypertrophic cardiomyopathy from the Atlas heart by the support vector machine, random forest, and artificial neural networks, prediction of all-cause mortality in patients suspected of coronary artery disease undergoing coronary tomography, arrhythmia detections by deep neural networks, detection of subclinical atrial fibrillation, identification of ventricular dysfunction, ejection fraction of less than 35% by convolutional neural networks, phenogrouping heart failure patients, and identifying who's going to respond to CRT implantation, automated analysis of cardiac structure and function, prediction of coronary artery disease on tomography, prediction of all-cause mortality from 1 to 5 years post CRT implantation, prediction of early coronary vascularization within 90 days after doing a SPECT MPI, identification of patients with pulmonary artery hypertension. Now, these are the various overviews I have given you. Now, when we talk about clinical decision support systems, this was a study done, published in JAMA, where from 3 academic medical centers in the United States, 26 attending physicians, 24 resident physicians, both were given 25 generative artificial intelligence chatbot. They were given 6 clinical visits, 60 minutes to find out. Once by using AI and the other through the conventional online resources like PubMed or Cochrane analysis. And there was no difference between the two. However, when ChatGPT alone was used for diagnosis, it gave a reasoning score of 95%. And that was surprising, possibly because the doctors were not yet ready to accept the clinical decisions made by the artificial intelligence. Now, there are certain barriers to implementation of artificial intelligence. We have, especially in our country, limited access to diverse high quality data sets. And there is a black box nature of many AI systems, which impedes clinical trust and adoption. There is a lack of clear legal and regulatory frameworks. People are not ready to adapt into the existing clinical workflow or incorporate the AI tools. There are challenges in protecting sensitive data, but the biggest problem that everybody is saying that there will be dehumanization of medicine. And this is an AI generated image of dehumanization of medicine. Then there are certain ethical considerations like transparency and explainability, fairness and bias mitigation. Human oversight will need to involve the humans in AI decision making process. Patient autonomy is very important. But I must emphasize here that AI enabled technologies should complement and not supplant the logic and decision making of physicians and other clinicians. Physicians should have the last and most important say when AI is applied for decision making in the medical field. The ethical dilemmas, we know it is rapidly evolving. At times, it may underperform or it may become unregulated. We have hallucinations. So, we need to have robust regulation and quality control. In fact, the FDA has recently released a regulatory framework with aim to establish safe and effective AI-based medical devices. These regulations need to be used also for upgrading the AI products. In fact, the AI projects need to be ethically acceptable, fair, non-discriminatory, and justifiable and worthy of public trust. Then only they can be used everywhere. Now, this is the quality criteria. There must be a clear intended use, rigorous validation, adequate sample size, openness of data and software, and reporting and reproducibility. Let's take a peek into the future. AI is going to be part of every cardiologist's daily routine. It is going to give him the opportunity to effective phenotype his patients, design predictive models for different disease, use non-invasive diagnostics, reduce the need for costly and complicated invasive tests for the diagnosis of coronary artery disease. They'll be by looking at the ECG and echo, they'll be able to tell an asymptomatic patient whether they will develop a lethal arrhythmia or a myocardial infarction and what needs to be done to avoid this. And this will be a game changer. So they must educate themselves in AI today. Let's look at the cath lab of the future. This is the cath lab of the future. And what it is going to do? It can help you in preparing the procedure, risk assessment, non-invasive imaging, early treatment planning, looking at the coronary anatomy, lesion characteristics, regional ischemia, lesion detection, characterization, functional flow assessment, and ultimately guiding robotic procedures. So the key messages that I want to give you, we should embrace our AI to not only automate our mundane paperwork to recover critical human time, but also allow us to practice and enhance our most human skills, that is compassion and empathy. There must be a constant pressure to test all AI as well as human intelligence systems in healthcare to ensure safe, credible, and compassionate counseling and advice for all. We must collaborate with scientists, physicians, and public and tell them the logic behind the applications. The future of AI will depend on how well we can align these systems with human values and ensure they produce accurate, fair, and unbiased results. While it provides unparalleled opportunities in the advancements of healthcare, a balance between leveraging the technology and retaining the human touch becomes vitally important. So, but what is my take on AI? AI is a powerful ally, augmenting human capabilities, enhancing diagnostic accuracy, streamlining workflows, and potentially elevating some of the burden that contributes to burnout. But when it comes to making sense of a patient's history, understanding nonverbal clues, building trust, and addressing the subtleties of human suffering, there is no substitute for the human touch. And a doctor's role as a healer, counselor, and advocate cannot be outsourced to algorithms. Medicine is learned at the bedside and not in machines. So ultimately, what we are going to have, we are going to use this artificial intelligence to boost our human intelligence and call it augmented intelligence. Now, I have a small tribute to the use of AI in cardiology. In the heart of lab, AI took the stage for some fun. Let's mend these hearts. It's my new endeavor. With algorithms sharp and smart and clever. The docs stood in awe. What's this new tool? AI just smiled. I am no medical fool. I've read all the charts, every beat, every pro, and tell you what's wrong with a precision show. It scanned and it beeped with a digital player. Your patient needs care, but don't despair. A tweak here, a dose there. I've got the plan. Trust me, dear doctors, I'm your right hand man. But then it went rogue, predicting some tunes. The heart beats in jazz with occasional tunes. Docs chuckled softly. You are clever, it's true, but leave the music to us, and then we will work with you. In the heart of the lab, AI is now a friend. With a blend of tech and docs, on the hearts we depend. Together they laugh as they heal with delight. For in the world of cardiology, AI is just right. Thank you for a patient hearing.
Thank you so much, sir. The talk was indeed very enlightening, and me as a medicine resident, I'm really intrigued, and it has really it is a very neuron jolting talk by you, sir. Knowing about positive predictive value for STEMI by the AI enabled ECGs is up to 89.5%, which also is significantly reducing the door to balloon time. Also, the diagnostics of with multitude arrhythmias of various types, such as atrial fibrillations, which was told by you. Then also wearables. Definitely, they are going to be a very portable solution and a very non-invasive solution for people, even for general population. Sir, now we have multiple questions from the audience, so I will just follow. I will just convey the questions, sir. First one from the audience is. How is AI improving the accuracy of early diagnosis in conditions like myocardial infarction or atrial fibrillations compared to conventional methods?
Right. As I talked in my presentation, as far as if you look the atrial fibrillation, there are times they are so subtle that the cardiologist may miss them on the ECG. In fact, I have personally missed it 2 or 3 times, and it was only when I reviewed the ECG again and again I saw I was missing atrial fibrillation. It was so subtle. So the AI-enabled ECG reading is going to catch that which we have missed. As far as the MI is concerned, I have already told you about the ARISE trial, where AI-enabled ECG can give you an early detection of ST elevation MI, where we may not be sure whether this is early repolarization changes, whether it is hyperacute MI, whether it is non-specific T wave changes. It can enable you and reduce the door to balloon time, which is the most critical part of the treatment of ST elevation MI.
Thank you, sir. So we have another question from the audience. One is which asks about cardiac AI protocols. Can it be hacked and do major damage to the patient? What is the safety protocol for the same?
What type of protocols is he talking about? I couldn't get the question.
Sir,
Yeah. I don't know. See, most of the data that is coming up is still an evolving time, and the most of the data is coming from the Mayo Clinic in US and a lot of Chinese hospitals. And of course, there's always a risk when you are going for a robotic procedure. there are risks. Who is responsible medically? Is it the robo? Is the doctor? I mean, these are things that have to be sorted out, and we need time, we need regulatory framework, and it's an evolving branch. And like any evolving branch, any branch that comes up, there are going to be hurdles, there are going to be obstacles, and there are going to be hiccups. So we need to wait, we need to learn from every mistake that we have made, and then we are gradually going to develop to fine tune what we have learned.
Okay, sir. Yes, sir. Thank you so much, sir. Uh, by now, I think we have these two questions from the audience. So, any more questions, Hitvi, from the audience, from the back end team? Sir, also I wanted to discuss about the preventive cardiology with AI. So, as rightly said, as rightly pointed out by you during the end of your slide deck, that it is also, it's not just the secondary prevention, but also the primary prevention, which is taken care by AI. So, how significant will it be in a country like India, where we have a tsunami of all non-communicable diseases adding up to the burden of card.
Absolutely, absolutely. It's going to be a game changer tomorrow. See, the biggest killer of heart disease, or the biggest driver of killer of heart disease, is diabetes and non-communicable disease, as you very rightly said. And even AI in diabetes has gone to a lot of steps. We have now something called mobile health, which is there's every person in our country is having a mobile phone days today. We have reached that stage. There was a time when Rajiv Gandhi introduced the computers and people were skeptical, but today every person has got a smartphone. They can download the apps. In the villages, in the rural area, you will see people have a phone, or if not a smartphone, at least a phone, and messages they can receive. So sending, the biggest power of AI is to send messages, so-called to give nudges for behavioral modification. The biggest treatment, or the most important treatment for any non-communicable disease, be it diabetes, hypertension, obesity, whatever it is lifestyle modification. And lifestyle modification cannot work unless there is behavioral modification. And behavioral modification, AI is helping us to give these messages, these nudges to people across the country that please do this, please take this diet, please get your blood pressure checked. And these, when they get the messages, they are getting something in the brain to look, somebody is asking me to do something good. Why I should? Maybe after one, two, three, people will react. And that will be a game changer tomorrow.
Yes, sir.
Plus, there are also, suppose in the remote, there is a doctor sitting in the primary care center, a patient comes to him with chest pain, ECG is ordered, he is unable to read the ECG. We can send the ECG, the AI enabled ECG is transmitted to higher centers, expert cardiologists will look at the ECG, tell him what to do immediately, or even telemedicine has now come up in a sort of big way,
Yes,
that
yes.
by telling him directly what to do, it's really going to be a game changer in the next 5 to 6 or 5 to 10 years. I think maybe 5 years down the line, the way we are moving is really going to change the whole scenario of how we treat cardiology or how we treat non-communicable disease.
True, sir. Also, in the AI with medical education, especially, sir, the digital stethoscope that you were talking about, it will help these young budding doctors like us to listen to different types of murmurs and heart sounds, which were very common previously, but lesions which are not very commonly seen today due to advent of new antibiotics and advent of further and better technology. But we would these digital stethoscopes which will record these heart sounds and will help us to continuously listen to them and learn better and diagnose better whenever such cases or patients come in front of us.
That's what the digital stethoscope is doing. It is going to transmit the murmurs so that the students can learn how a murmur sounds like. And I was just reading today that the director of IIM Kozhikode, he has said, I would love to see my students use ChatGPT for research also, for education also, but also use their brains to to critically analyze what the chat GPT has given. So it's not that you blindly use it. You take its help. There is no harm in admit that you have taken the help of AI. That is very important. You must be honest to what you are doing and then critically analyze what it has said. Now you have a patient, he has come with certain symptoms. When you look at him, your differential diagnosis is limited by your knowledge. If you put it into AI, it's giving you 10, 20 different knowledge, differential diagnosis, and maybe your going to mind is going to strike, oh, this could be the main reason for this diagnosis. So there it helps you. It sort of tunes your brain, look in the right direction. And I always say, when you are, it's a wonderful example. You're walking in a dark forest, absolutely darkness, you can't see anything. Then you have got a torch in your pocket. You take out the torch and switch on the torch, and you see it illuminates your path. Torch is not showing you the way, your eyes are seeing it. So torch is just like AI, is illuminating for you for what you should see and how you should take action. So it is just a help, it's just an aid, it's just an ally. Use it as an ally. Don't depend on it completely. It is an ally for you. Use it as an ally, and ultimately it's your eyes and brain that are going to show you which path is the correct path to take. It's just illuminating the path.
Okay, sir. Thank you so much, sir. Thank you so much for an enlightening talk on cardiology. Now we move on to the next talk, sir. For the next talk, I would like to invite, it is my privilege to invite Dr. Prantar Chakraborty, sir. He's a consultant hematologist at Zoho Corporation, Tenkasi. Sir is a founder and CEO of Chew Mentor Academy, Mastermind and Cybernetic Care. He's specialized in Mastermind and Cybernetic Care, and he has 4 patents filed to his name. We welcome you, sir, and it is an honor to have you today with us, enlightening on hematology from microscope to technology, microscope technology.
Good evening, everyone. So, from microscopes to models, and I am so thankful to Dr. Anil because he set the tone. But hematology, if you look at what's being done here, it's actually a poorer cousin. What I'm trying to show you here is if you look at the FDA submissions for AI devices, on top is radiology, and then it was cardiovascular, and here is hematology, right? This is obviously data from 2023, but still, we, though being dependent on laboratory diagnosis, so many devices or products are not there. Now, those who know about hematology, the study of blood disorders, know that especially for cancers and other complex diseases, including genetic ones, our challenges are predicting them, screening for them, diagnosing them, trying to risk stratify, and then choosing the best treatment which is safe and effective, monitoring the patient and follow up. We have converted cancers into chronic diseases. So what can AI do? It can actually help us in all these areas, and I'll give you a brief glimpse into what is being done. So if you look at the annual occurrences, once machine learning was there, you can see leukemia, flow cytometry, ALL, acute myeloid leukemia. These are being cited more often. And way back during COVID, our journal, that is the British Journal of Hematology, actually published a review article on machine learning and artificial intelligence in hematology, where they explained the process in a simple way, understanding the problem, understanding the data, preparing it, modeling it, evaluating it, and then deploying it, and then scaling it up. So, there are various review articles which say that they can help as they are predicting coronary artery disease. Can they predict cancer early clinical detection of cancer? It holds a promise. There are future models which are now being tested, but there are not many clinical trials to date. But if I go to the lab hematology part, it is always debated whether it's a game changer or is it a gadget, right? And as Dr. Anil was explaining to you, it's a tool which can be properly used in certain areas. So you use the same microscope, right? But then you do a machine learning based image segmentation, then a deep learning based cell type classification, then some humans do the corrections. These results are fed. Again, another human experts look at it. Meanwhile, another system does a whole slide image analysis. Another system tries to extract morphologic features associated with genetic aberrations, because you are getting clinical data from EHR and genetic data. And then this is the hematologist sitting here who also suggests the correction and then makes it work. So, there are these hematology analyzers which can have images just like a peripheral blood smear, but they are actually developed by pattern recognition, and different white blood cells types are developed by them, and without seeing the actual peripheral blood smear, it can generate images and can help the diagnosis. So labs have already changed. For hematology, AI is not the future, it is the present. Previously, what the model was, peripheral blood film pathologist looked by light microscopy, generated a report which entered into the lab information system. Now, this has been there for more than 20 years. Digital site scanner, they are digitized. What is new is this AI model, quality assurance, flagging cells of important interest, triaging cases, rejecting poor quality scans, getting rid of noise because stain deposits and others, and then it suggests a differential count, provide an explainable AI, and I'll discuss more on this because our team has developed something on it, provide a report and diagnosis. It is reviewed by medical technologist, and then other information come in. It goes into the LIS, you coordinate it with the EMR, and then the clinician takes a decision. This is the model which is being followed by some of the top notch laboratories today. And if you look at image transformation, because it's all mathematical, and LLMs are basically statistics on steroids, each dot can be transformed. Then you can use several models like DNN, XGBoost, or support vector clustering, and you can classify it with the help of experts. You correct the misclassifications because you know that they can hallucinate. On the other hand, from the sample, you use fluorescent tag dyes, monoclonal antibodies. This data is processed because the cell counters today also are mini flow cytometers. They all go in here, and a more accurate diagnosis is made. So suppose you have a flow cytometer, but you cannot use many antibodies because of cost reasons, and you do not have an expert flow cytometrist. So you can just use it and then upload it, and you can transfer it. The deep learning models, they can classify it, they can get the flow cytometric data, they can use a base neural network, weightage to the models, and then predict the classes. So this is possible today. This was possible way back 4 years back. Cytogenetics, karyotyping was a major challenge for humans, and people needed years of training. Now you have machine learning based image segmentation plus geometric transformation, correction of misclassification again by humans, and a karyogram is produced, and then prognostication is generated based on expert evaluation using ML. So if you talk of the exposome, right, we have looked at genome, proteome, metabolome. Now we are talking about the exposome, what we are exposed to, the internal environment and the external environment. So you get clinical data, you already have randomized controlled trials looking at different tests and different therapies, you have a genetic profiling, if you have digital twins generated, right? So in very simple terms, Google Map is a digital twin of your roads. So you can develop similar digital twins for every human being. And then from drug discovery, you have certain data, receptor knowledge, prognostication systems, you integrate it so you can have targeted diagnosis, targeted therapy. In silico screening gives you faster new molecules. So are we not using it? This is 2 years back. So we had IPSS MDS score, right? International Prognostic Scoring System. We have added AI, and now we call it the AIPSS MDS score. So this Spanish GSMD data already has data from 7,000 patients. A machine learning algorithm was trained, and external validation confirmed superiority over the RIPSS of AIPSS. But these are still not randomized control trials. These are more of retrospective analysis with some degree of expert evaluation. So, especially in hemato-oncology, which is today's topic, what are we trying to do? So, when I showed you the citations, now you see our main target, almost more than 60% is AML and ALL. Obviously, because this kill patients more. But we are also using it in CLL, CML, and lymphomas and others. So, this is where the focus is. Now, imagine, can you diagnose acute leukemia without looking at the blood cells? Medical students, even doctors would think that I am mad, right? Without looking at a peripheral blood smear, without looking at the cells, how can you tell that it's acute leukemia, that there are blasts? Well, this has already been published in Lancet Digital Health. Evaluation of an ML model based on laboratory parameters, multi-center model development and validation study in France. And what did they use? They used certain parameters which had nothing to do with looking at a peripheral blood smear. Fibrinogen, which can be automatically generated, MCV, prothrombin time, LDH, percentage monocyte count, which the cell counters are capable of doing, MCHC, and then age, lymphocyte count also generated by the cell counter, platelets. And this is what they have got area under the curve. So they can even distinguish between ALL, AML, and acute promyelocytic leukemia. So AI PAL, that is what they call it, artificial intelligence prediction of acute leukemia, could help guide urgent therapies. They can be implemented in district hospitals who just have an automated cell counter and an automated biochemistry analyzer. No cytologist available, no hematologist available. Still, the diagnosis can be made and they can be referred to a proper center. If you have flow cytometry, there are so many nuances there, and a person needs to work for 10 to 15 years for understanding the nuances. Gating, which is a very important technology, the pathology students will understand that the entire diagnosis can change based on gating. So what they have tried to do is do an automated gating looking at the machine learning model, looking at the attention value using certain models. And if you look at manual gating, this has been done by a flow cytometrist who has been trained for 15 years. And this is what the machine did, right? It's almost similar. It is almost similar. The chance of error is less than 3%. And then as you generate big data, for precision medicine, AML is one, where we have had some cytogenetic risk stratification, but still we can't predict what would happen to an individual patient. So now you look at single gene studies, they took only 30 AML patients. They looked at 20,000 genes and 53 drugs, right? If your AI was not there, it could have been, because this is so much data on only 53 drugs, there could have been a problem. So now you use some regulator, mutation, and other genes, classify them, do certain models like merge, elastic net, and then you see that there is a distinct classification which tells you that which AML will respond best to which drug. And most of these drugs are now available in India, but no randomized controlled trial has been conducted. Now, looking at an ensemble model for AML risk stratification, you combine machine learning with clinical guidelines. So the clinical guidelines are the European Leukemia Net guidelines of 2022, and ensemble is a machine learning model. If the prediction is identical, yes, that is the final result. But if these two are not concordant, right, then what do? Adverse versus favorable, whether predict the opposite. If they predict the opposite, you take an intermediate path, just like Lord Buddha. But if it says that adversity is there, you can consider the ensemble model. This was the study. And actually, if you look at how many classifications, stratifications changed, I've shown you this. Some from adverse became intermediate, some from intermediate became favorable. And that actually, this was from the National Cancer Research Institute cohort, that helped us manage the patients better. So this is the overall survival curve from ELN 2022. This is from Ensemble. And when you use both together, you can see that the gaps are better, right? So this is what machine learning can do to your conventional guideline. Now, if you harness for risk stratification, evaluating the utility of longitudinal electronic health records, you use graph neural networks. So, death predicted, survival predicted. These are some of the data. I'm not going into the details, but it also has genetic data, it has pathology reports, it has karyotype, and even what drugs they're using. And they have been successful in predicting death. So, in the management of AML, in 2023, we are using data knowledge, medical data, including registry data, clinical trial data, ML technology for data preparation, for modeling, for training and validating. And this is what we are getting in terms of decision support, drug development, warning systems, and prognostications. But it is still work in progress. Machine learning applications have been used because ALL is a good disease in children. We knew some of the conventional things, like if the age was more than 9 years or less than 1 years, if the count was high. Now you have something else there, and you put it into a model, and it gives you a beautiful curve so that you can predict with 90% certainty which child will relapse. There are already online tools where you can go and use them, and I always say play with them. There's another which has been developed originally by a patient who had lymphoma. They're using data scientists. Even students can load their data here. There are certain models. You can just play with those models and understand that from the methodological role, we are going to a translational role. We are trying to understand the resistance mechanisms, characterize the tumor phenotypes because it's a heterogeneous basket, and optimize the patient treatment, reduce the overall cost. Because the modern molecules which I showed you, they are prohibitively expensive. So what have we achieved till now? Automatic detection and classification of single cell images from digital microscopy, making the flow cytometry data better, aiding cytogenesis in karyotyping, developing personalized models. When you say, you have a 50% uh, survival rate, it means nothing to the patient. For the patient, it is either 0 or 100, right? So, how do you individualize that data? And how do you estimate the response to certain therapies, or whether they do not work so you don't waste your money, and try to predict the prognosis? After that, I'll come to what I have tried to do with different teams, right? So, this is what we did, and this was published in Big Data Analysis in 2019 using an artificial neural network. Using the eyes, we tried to predict whether this person has anemia due to iron deficiency or due to thalassemia disease, and we tried to even identify thalassemia carrier detection, because You need to do an HPLC, which is quite expensive, and it's also a closed technology. Now, working with Indian Statistical Institute, their machine learning unit, we have already developed this model called pathologist like explanations, which is an explainable deep learning system. It's not a black box like ChatGPT or even DeepSeek. We have taught the model exactly how the pathologists are taught. So they look at the size of the cell, they look at the granularity, they look at the nuclear cytoplasmic ratio, and then they have been taught, okay, what is the granularity, what is the cytoplasm color, what is the nucleus shape, and what is the nuclear cytoplasmic ratio. And after that, it gives you a diagnosis. So you have class level prediction, bounding box prediction, a transformer model, which is again open source, and we can share the code with you, and then it gives you a diagnosis. And if you use it more and more, if it commits mistakes, you become the trainer. So some supervised, some unsupervised, but everything is open source. If you want, I'll share the link of this because it's a government intellectual property, so it needs certain permissions. I have a thalassemia patient who is now doing PhD in digital health. Thalassemics, especially those who undergo removal of their spleen, they get a lot of nucleated RBCs. Okay, nucleated RBCs, which even a trained pathologist may sometimes interpret as lymphocytes. So, in automated cell counters, suddenly you see a count of 50,000, 60,000, and it has happened in a small city. They called to tell me this patient has acute leukemia. No, those are all nucleated red blood cells. To solve this problem, he has used existing models and he has used open source images and he has classified them. This has already been published, and we have seen that certain models do a better work, but it needs real world validation. Now, talking of LLMs, right? We know that there are not enough hematologists in the country, and that's why there's sometimes a lot of delay in reaching the right person. So we gave a problem. We have integrated LLM into certain electronic medical records. We say a 23-year-old lady presents with fatigue for 2 weeks, fever for 1 week, gum bleeding, menorrhagia for 3 days. And on examination, she has generalized lymphadenopathy, hepatosplenomegaly, and sternal tenderness. Any student, even in the third year, fourth year, fifth year of MBBS, can give this basic history and findings. And then we tell the model, you are a physician, not even a hematologist. Based on the below notes, provide an assessment diagnosis with ICD, prescriptions be as accurate, and give your suspicions, right? Do not hallucinate. Look at the response, and this is a real life response. It says that the combination of symptoms suggest a possible hematologic or oncologic underlying condition with a need to rule out infections and autoimmune disease. Possible diagnosis: number one, acute leukemia; number two, aplastic anemia. But it says the presence of generalized lymphadenopathy and hepatosplenomegaly is less typical. Tell me, an intern who has been placed in a primary health center and who is just learning the nuances of clinical medicine, this kind of LLM integration in the electronic medical records can help that person. And the suspicion of the model is, given the presentation, acute leukemia is a strong suspicion. So it aligns closely with hematologic malignancy. And it tells, even if it was someone who just can give a history and maybe some findings, it says immediate referral to a hematologist, oncologist, and this test need to be performed, right, to confirm the diagnosis. What is supportive care? You may need to give platelets. What is specific treatment? It does not replace a hematologist or a physician. But as Dr. Anil was telling you, it's your friend, especially when you're alone in an uncharted territory. This is a graphic we generated in 2021, where we said that augmented intelligence will convert hidden knowledge and unknown knowledge to knowledge, correcting it from wearable, smartphone, tablet, web browser. We were using Neo4j, and we were using PubMed, Panthers, ICD, SNOMED. Now, with LLM integration, this is a reality, and this is how we are going forward. But people still ask me, I mean, let the technologies do their work. We will see when time comes. You can't afford to do that, right? Please don't leave it to others. Please do not leave it to market forces, not to investors who are looking at return on investment. It has to be a fair playground, and you, as a physician, should be the referee. Then only you will get to help the people without discrimination, without bias, in a fair level playground. Thank you very much. I now stop sharing.
Thank you so much, sir. This was indeed another very interesting highlight, another very interesting talk, highlighting the importance of AI and the system-wise formulations which has been done, which further aids and it tries to break ground to a more individualized and a more uh, concise and a cooperative management of a patient. So I will just reiterate the questions from the audience. So first question is, how accurate is AI in classifying leukemia and lymphoma subtypes?
Yeah. So the accuracy depends on what you're trying to do, right? If you are only looking at a peripheral blood smear, i- if the image quality is good, that is the most important thing, because how you stain it, still you need to stain it. So you should train the technologists. If you stain it well, it is correct in more than 90% of cases. If it is stained poorly, if the image is not captured properly, or if you're looking at the edges of the peripheral blood smear, then your chances of error would be as high as 20 to 30%. So you have to take care of the pre-analytical components, then only the model will help. And the model will learn as you use it more and more. That's why I showed you explainable AI, which we have developed, which is an open source thing, but it needs more and more. And mind you, images under Indian conditions, images captured by phones which are there with our Asha Didis or maybe with our paramedics, medical technologies, and then it will improve. Nothing is 100% accurate. And remember, ultimately, the report has to be signed by a human. It's just that the human knows what it is showing. Like, I'll give you an example, right? It has told that there is a chance of acute leukemia. The system should show you why. Where are the blasts? And if it looks to the human eye, you can safely sign the report. So it's not a all or none thing. It's about an expert, but that expert may be sitting in a city. The diagnosis can be made at a village level at the point of care. That is the beauty of AI, because it saves the time of the expert also. He does not need to look, he or she does not need to look at the entire slide. It looks at certain images which have been captured. And if there are no artifacts, immediately the diagnosis.
Okay, thank you, sir. And there's another question: is AI reliable in predicting relapse or treatment response?
Yeah, so the prediction is very important, but it has to be individualized. The more data you train it with, so it's not about, the classical things we all know, so that is fine, but you treat more of genomic data, you treat more of drug data in vitro, you treat more of, if you have treated say 100 patients of a particular leukemia in your center, that outcome should be there in the model, then it will be more accurate. But if you're using a Mayo or a Stanford model and using it for an Indian patient, the chances of error are more, because their genetic makeup is different. Their so many enzymes are different, so that cannot predict it. You generate your Indian data, you share it truthfully, and they will be more accurate.
Thank you so much, sir. I think there were a lot of takeaways from your talk, and again, it was another very interesting insight into how there are multiple steps in the laboratory diagnostic models, as which has been very well highlighted by you or your slides. Also, sir, there are more accurate diagnosis, transfer of learning systems wherein the whole system and the images are being transferred to a higher center in order to make a more individualized diagnosis. And also the value of prognosis in AI, which is also the also which integrates personalized models, individualized therapies along with prognostic values. Also, sir, a very interesting model of exposomes, which enlightens us with genetic profiling, as well as the concept of having a digital twin, which further inculcates to have a more individualized therapy and to have a better prognostic idea about a condition of the patient. So also the acute leukemia without looking into peripheral smear. So there are lot of new insights which are coming in, and we are definitely looking forward to having more such cases, more such talks. And it is a pleasure to have you and Virmani sir again. Any more questions from the back end? Okay. So, sir, these are the total questions. Again, it is our pleasure, it is our privilege to have you and Virmani sir to talk on such important and such prevalent conditions which are very 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 important in our country. Also, at the outset, I would also like to thank Dr. S.V. Kulkarni sir, Dr. Alok Modi sir, and Dr. Amit Kumar De sir for giving us a chance, for giving me a chance to moderate the session. Also, Dr. Aishwarya Sharma for coordinating, and Dr. Hetweave and MedSynapse for the backend support. Again, from Doctors AI, I would like to thank Dr. Prantar Chakraborty sir and Dr. Anil Virmani sir for their excellent speech and time to enlighten us on the topic. Thank you so much, sir.